thank you so much for joining today. We will be talking about the study you discussed at ASCO with an antibody that targets CCR8 in gastric cancer. Can you just tell us a little bit about the study design and the agent that was investigated?
Sure. So this was actually a pooled analysis from 3 different studies. This was there were study sites in China, Australia, and the U.S. And they used slightly different PD-1 inhibitor and dosing of the study drug. But ultimately they all had similar treatment regimens with an anti-CCR8 antibody plus a PD-1 inhibitor. And this is in patients with at least the cohort that was analyzed at ASCO was patients with advanced gastric cancer that had been previously treated with at least 1 line of prior therapy.
So what is CCR8?
So CCR8 is a very interesting marker that is a relatively new marker that is found mostly in T regulatory cells, and mostly T regulatory cells that are within the tumor microenvironment. Doesn't seem to be found as much in other types of T cells, and doesn't seem to be found in T regulatory cells in other places like the skin. And so it really is an interesting target. And the antibody that they're studying is a depleting antibody. It's FC modified to try to remove these T regulatory cells from the tumor microenvironment to remove the immunosuppressive effect of them.
And so clearly there were some promising results that were seen because it made it to the oral abstract session. So can you just share a little bit about what was observed, and you were the discussant, of course, for this session?
Yeah, so they saw a fairly high objective response rate. We know that second line and later gastric cancer patients generally have very limited systemic therapy options. And 90% of the patients in this study had received prior PD-1 therapy. So although they were getting PD-1 again, it wasn't a PD-1 phenomenon, because most of them were refractory to that already. And their objective response rate in the overall population was, I think, 38%, and even higher in the second line setting. So it got lower in later lines of therapy, but quite promising. And many of these responses were fairly durable. The data was still fairly immature at the time of presentation, but most of the responses were ongoing, and the majority of them were ongoing at least 3, and many of them beyond 6 months. So it appeared to be a true immune response in the patients who were experiencing it.
I think it's so exciting to see responses, especially in patients who had prior immunotherapy exposure, since these agents were initially developed in 3rd-line settings, 2nd line, and then moved into 1st line. And so we have no use of immunotherapy, or no evidence that immunotherapy type agents work after progression 1st-line therapy. But I think certainly we need to explore the activity of these drugs in patients from Western countries as well. There's other companies who have anti-CCR8 antibodies as well, but nice to see this activity. Are there any toxicities that we should be concerned about with these agents?
Not that was presented. I mean, again, the data was fairly early. And so, I think that the toxicity data that was presented looked not dissimilar to just PD-1 monotherapy. There was a variety of, 1 or N of 1 or N of 2, single patient organ toxicities, of higher grades, and then, sort of the lower level toxicities that we see that are sometimes from disease and sometimes from the immunotherapy in these refractory GI cancer patients. So no real signal that it was any more toxic than PD-1 monotherapy, but I think too small of a study to really feel comfortable making that determination.
Right, and short-term follow-up, of course, also makes it, we need longer time follow-up to know whether there's any immune-mediated toxicities with these drugs too.
Yeah, and certainly need to see toxicity, especially we need to see in a Western population as well, just to kind of understand, again, in the population of patients that we treat, is it the same safety profile?
Well, thank you so much. Exciting data. Hopefully more to come, and hopefully we'll have studies in the US as well with some of these agents to introduce these agents to our patients. Thank you.
No, certainly. Again, I think I agree with you. We need to see more data, both in other diseases and from some of the other agents that are emerging. I think it's a really interesting target, though.